How well do you know the local anaesthetics you use on your patients every day? I can assure you that by the end of this episode of ScheinTV, we're all going to know our local anaesthetics a whole lot better. We're joined by 3 experts in dental anesthesiology who will guide us through contemporary controversies in local anaesthesia and help us to get the most out of these vitally important drugs. Dr. Greg Marnie has worked, studied and taught extensively in pain control, anxiety management and dental risk. He's the current president of the Australian Society for Dental Anesthesiology and serves multiple roles with the Dental Board of Australia and the Queensland Health Ombudsman. Originally from the UK, Professor Nigel Robb has been president of multiple peak bodies concerned with dental anaesthesia around Europe, and he's also a renowned expert in conscious sedation. Dr. Wolfgang Jakobs is widely published in oral surgery, implantology and anaesthesia in dentistry. He has served as president of various European and international peak bodies in dental anaesthesia and is the current president of the German Association of Oral Surgeons. Gentlemen, welcome to ScheinTV.
Thank you.
Thank you.
If you're watching us on the Henry Schein website, you can submit comments and questions on your current screen. Depending on your device though, you might need to exit full screen mode first. If you're joining us on Facebook Live, make sure you're watching us from the Henry Schein Facebook page. That's important because we won't see your comments and questions if you submit them from any other Facebook page. And remember to like and share this post. I guarantee your colleagues won't want to miss this event. Our discussion will last about an hour and we'll let you know at the end of the episode how to claim your CPD certificate. Let's get into it, gentlemen. Obviously, there are plenty of anaesthetic products on the market. Nigel, does every anaesthetic work for every application, or does the anaesthetic molecule itself make a difference?
The anaesthetic molecule does make a difference. The different local anaesthetic preparations we have differing degrees of potency, differing degrees of diffusing power, and also differing lengths of time of action. Historically, we were all brought up with lidocaine or lignocaine with epinephrine as the standard local anaesthetic of choice. But since its introduction in the late 1970s, articaine has gained increasing popularity and has been demonstrated to be more effective in a number of indications, and therefore I think worldwide now is increasing in popularity. We talk about its efficacy first and then we can move on to its safety. I think Wolfgang would probably like to pick up on that.
Thank you. Now, in order to explain the superiority of articaine to lidocaine, we have to know that to block a nerve, a sufficient amount of sodium channels have to be blocked over a sufficient length of the nerve. And the potency of the drug is related to the ability to block the sodium channel. And articaine is superior to lidocaine because it has a higher lipid solubility, so it is able to penetrate the nerve membrane faster. The second thing is the protein binding. Articaine is able to attach to the sodium channel, to the protein in the sodium channel, and therefore this explains the superior efficacy of articaine in many indications. And the third factor is also the pKa. The pKa is actually the pH when half of the drug of the injected local anesthetic is in base form and half of the drug is in the charged form. Unfortunately, only the base form of the local anesthetic is able to penetrate the nerve membrane. Therefore, as more base form molecules we have, as more efficient is the local anesthetic in regard of onset of anesthesia, faster onset of anesthesia. And articaine has a lower pKa as lidocaine, therefore more base form molecules are there, and this also explains then that they can attach to the sodium channel faster, and the onset of anesthesia is a little bit faster for articaine than for lidocaine.
Well, if we're looking at the efficacy of articaine, is that across all dental anaesthetic techniques, or are there injections and injections when it comes to where we should ideally use articaine?
Actually, articaine is superior when it comes to the diffusion, and therefore, according to the latest literature, 2019 reviews and meta-analysis, articaine proved superior in most indications. There's only one indication, that's infiltration in the maxilla. is that Articaine and lidocaine have proven similar efficacy.
But
Other than
everywhere
that,
else it was
in
hands
all
down.
other indications, Articaine was superior to lidocaine in the inferior nerve blocks, infiltration in the mandible, and also in the so-called hot tooth in cases of pulpitis. Articaine showed superiority to lidocaine in all these indications.
We have questions pouring in about Articaine
Yes.
in inferior alveolar nerve blocks, and we will get to that. Before we get to that, though, we've covered the efficacy. What about the safety? Greg, can you talk us through the safety of Articaine versus other anesthetics?
Well, I think on the safety aspect, we've got a couple of things. One is the half-life of the actual drug itself. Because it's got that ester link on it, it's metabolized in the blood plasma by the cholinesterase. So it actually has quite a short half-life in the blood. So around about 20 to 30 minutes. The other thing about it is that it's metabolites. It's a very simple metabolite. Because it's been processed in the blood, 95% of the byproducts of that metabolism is articanic acid, which is totally inert. So that speaks volumes to its safety. Right.
I think we have a couple of slides to talk about efficacy and safety, so could we just have them on screen now? And Nigel, could you talk us through this slide?
Yes, this slide basically shows what happens to the plasma levels when you have repeat injections. And you can see that the blue curve for Articaine and the black curve for lidocaine are broadly similar for the first portion after the first injection. Then you can see the plasma level of the Articaine dropping off much more rapidly than the lidocaine, reflecting the shorter half-life. At the point of the second injection, you can then see that the levels then start to go up, but the level of the lidocaine goes up much higher than that of the Articaine, meaning that you have a much higher concentration in the blood. And with the repeat injections, that gap between the concentration of Articaine and the concentration of lidocaine increases, meaning that as the potential for toxic reactions is directly related to the plasma concentration of the drug, the fact that the Articaine has a significantly lower plasma concentration means that it is likely to be significantly less toxic. In terms of efficacy, Wolfgang was talking about some of the articles, and this slide is basically a summary of one of the systematic reviews that concluded that the Articaine was significantly better than lidocaine with epinephrine when the epinephrine was in the same concentration across the two preparations. That's been replicated a number of times. This particular article was from 2007 and was one of the first systematic reviews, but there have been a number of others, culminating in the latest one this year that had exactly the same results. And as Wolfgang said, the only area where the evidence isn't wholly in Articaine's favour is maxillary infiltrations, and that's because we all know that maxillary infiltrations with lidocaine are so effective that actually it'd be very difficult to prove any benefit. Although there was one study some years ago that did show that Articaine was more effective in an infiltration over an upper lateral incisor than lidocaine, and I've got no idea why the upper lateral incisor should be the tooth that showed that effect, but it was actually shown.
Throw it in there for interest.
Yes.
Well, thank you for your questions. I promise we're getting to we will get to as many as we can. If you're watching us on Facebook Live, make sure you're watching us on the Henry Schein Facebook page, because we won't see your questions if you submit them on any other page. And if you can, remember to like and share the post as well. Well, gentlemen, we've had thousands of questions pouring in both during the webcast so far and also beforehand about Articaine and inferior dental blocks. So let's get into it. Look, it's a big call, but we've had a question: is Articaine absolutely safe for blocks? Wolfgang.
Yeah, I will say it is. We have ongoing discussions wherever Articaine was introduced in the market, recently introduced in the market, about possible neurosensory disturbances. We call paresthesia, dysesthesias, neurosensory disturbances after the use of Articaine, after nerve block. Actually, all injections in this pterygomandibular space, this is a space where there are very nerves and also it's a high vascular area, we can have damage with all kind of needles when you're penetrating for a nerve block. But this is a mechanical reason. But beside that, there's no reason that any specific local anesthetic can cause more nerve damage than another. There is no higher neurotoxicity to articaine in comparison to other drugs. The second reason why there was a belief that there might be a higher neurotoxicity of articaine is a 4% concentration. Articaine comes in a 4% concentration, lidocaine in a 2% concentration. But if you look in the literature, there are many papers comparing the different local anesthetics and their neurotoxicity. And articaine in all these studies proved to have a lower neurotoxicity than lidocaine. And the second thing is that the 4% solution doesn't make the difference. It's the molecules, the number of molecules, and cause, of course, neurotoxicity. And lidocaine has a lower molecular weight than articaine. Though 4% articaine solution doesn't mean necessarily that you have the double number of molecules causing neurotoxicity. In our group, we did a lot of research in these reports about neurosensory disturbances. And actually, I follow up all the reports, ADR reports about neurosensory disturbances worldwide.
That's an adverse drug reaction
yes,
report?
from all drug producers, articaine producers worldwide. And actually, we are able to oversee in this moment 1.9 billion sold local anesthetic units. And if you can see maybe on the next slide, I would like to show you the numbers we evaluated during the last years. In 2007, we had an incidence of reported neurosensory disturbances to the manufacturers of 0.22 per 1 million injections. Then the number dropped to 2008, it's 0.89. In 2009, we were down to 0.27. And then we had an increase again, 0.81. And then it dropped down, and now we are in 2015, and I guess in 2016 will be the same, 0.25 occurrences of neurosensory disturbances following the use of local anesthetics. And this is about 2 per 10 million injections.
I know that those carpule sizes are 1.8 mils.
Yes.
Obviously in Australia we have 2.2 in
yes,
general.
yes.
Should we be expecting much difference in those numbers here?
I don't think so. I don't think so. We calculate, and there's no other way to calculate, one ampule for one injection. That's, I think, just for the calculation. And if we have the relation then of 1.9 billion sold, and you see the adverse drug reactions, then of course you get an idea, a rough idea. Even if you know that underreporting is very common for side effects. But if you're talking about a permanent nerve damage, I doubt if there is a very high underreporting, because this is also a medical legal issue and it will be reported. And if I can show the next slide, and I would like to explain the numbers for 2010. And if you look at the numbers for Denmark, in Denmark alone, there were more neurosensory disturbances reported than in all the other European countries together, almost as much as the United States. And if you compare Denmark with 7 million people and the rest of Europe with 300 millions, you have to see that there might be a bias in these numbers. And we are down now again to 0.25 per 1 million. And the explanation is, I mentioned before, that wherever articaine was introduced in the market, we had a higher reporting. And this is a well-known effect in pharmacology. It's a so-called Weber effect. Whenever a dentist or a medical doctor use a new drug, the inclination to report possible side effects is much higher than with an already long introduced drug like lidocaine. Lidocaine was introduced in 1948, and it was the gold standard for centuries. And if you look in the data, actually, there is no evidence at all that there's a higher risk for neurosensory disturbances with a nerve block with articaine. And therefore, in Germany, we have a market share for articaine for 98%. And we have no restrictions at all in using articaine for nerve block. So I think articaine has a higher risk for neurosensory disturbances in the myth and not a fact. Yes.
So it's a myth, not a fact. So
yes.
If I can summarize what you're saying, Articaine is not absolutely safe, but then nothing else is absolutely safe either. It's just as safe or dangerous as the other anaesthetics. Is that
The
correct?
application itself is not safe. There's no difference if you make an application, if you're a nerve block with maybe mepivacaine or lidocaine. Actually, there are two very important risk factors in regard of the inferior nerve block, yes. And this is a second injection in an already anesthetized area. Every dentist knows the effect. If you do an inferior nerve block and you hit the nerve, the reaction of the patient is to withdraw from the injection, yes. But if you have already done a first injection in this area, you might miss this reaction, and then you are able to inject directly in the nerve. And direct injection in the nerve causes bleeding, hematoma, edema, and maybe scar tissues in the nerve. And this scar tissue is dangerous. It can last forever. But this can happen with all injectable local anesthetics. It's nothing that's related to Articaine. And the second factor is the needle itself. So if you have an already multiple used needle with barbs and the tip of the needle is not sharp, then of course by hitting the nerve you can of course make more damage to the nerve than with a new needle. And these risk factors are really acknowledged risk factors: re-injection and multiple use needle for a second injection, inferior vena nerve block. And if you see the data, the risk is very, very low, and there's no scientific evidence at all that 4% Articaine has a higher risk for neurosensory disturbances than lidocaine.
Greg, I think you had something to add.
Yeah, just in the Australian context about the 2.2 versus 1.8 mil cartridge, I don't think we're going to see any difference because it takes exactly the same amount of anaesthesia for an upper lateral in Australia as it does for Germany. so I don't think we're going to see any difference at all. I think the only thing that happens in Australia sometimes is that people tend to give too much. Mm-hmm. They don't, we always ask, how much should you give? The answer is enough. It's not, you should give, 2 mils of lignocaine in a lower block. That's just totally unnecessary. Mm.
Well, if we can stick with you, Greg, obviously you have a substantial background in dental risk. We've had a question, and thank you for your questions, about what kind of consent we should be getting from our patients about the risks of local anaesthetics. Okay.
I think the Australian population are well aware of the risks of any injection, but the College of Anaesthetists in Australia do ask that we do get consent. So that consent can be purely verbal. Okay, so you would say to somebody, I'm going to give you, do you normally have local anaesthesia for your filling? And they say yes. Would you like the local anaesthesia? Yes, that's consent. Mm-hmm. So I don't think you have to actually physically fill out a special form to say that that this person is consented to having local anaesthesia. Yeah.
All right. Well, let's move on to adrenaline or epinephrine. Yeah. What can you tell us about the different concentrations of adrenaline, Nigel?
Well, historically, Australia and the United Kingdom have tended to use 1 in 80,000 epinephrine, and the rest of the world has tended to use 1 in 100,000 or 1 in 200,000. It must be said that actually I know of no significant evidence that says that the 1 in 80,000 is actually of any benefit to our patients. And in fact, there is some evidence that the higher the concentration of epinephrine in the local anaesthetic, then the greater the likelihood of side effects from that epinephrine. So therefore, we should be using the lowest amount that we can physically get away with. And in terms of the vast majority of indications, there is absolutely no reason not to use 1 in 200,000 epinephrine. It will work just as well. About the one time that dentists might notice a difference is that if they're doing things like flap surgery or perhaps removing impacted wisdom teeth, which is more Wolfgang's field than mine, they would notice a bit more bleeding around about the time of surgery, which might mean that their assistant has to work a bit harder to keep the field clear for them to see. But apart from that, there is no benefit. I suspect that the reason that it's still marketed with that concentration is down to the conservatism of the profession and the fact that they don't like change. One very interesting finding on that point of view was when I was working in the UK, at one point we had a great shortage of local anaesthetics because of a problem with one particular manufacturer. And dental practitioners were using whatever they could get hold of. And many of them were using 1.8 cartridges of lidocaine with 1 in 100,000 or 1 in 200,000 epinephrine. And when I was doing postgraduate courses, I would ask them, did you have any problems when you were using that? And universally the answer was that they didn't notice any difference in terms of their experience or their patient's experience.
Well, Wolfgang, what has your experience been in a surgical setting?
I think for third molars, Nigel mentioned it, there's no difference. And there are also studies proving that there's no difference. But indeed, there is a difference in certain forms of periodontal surgery. If you would like to have a field without bleeding with hemostasis, with maximum hemostasis, and of course the 1 to 100,000, like Nigel said, proved superior. But we should see that we have a megatrend in dentistry nowadays. We have more elderly patients and we have patients with multimorbidity. And the American Heart Association momentarily says we should in dentistry use the lowest effective dose of epinephrine. A couple of years ago, the statement was not to use local anesthetics with a higher concentration of epinephrine than 1 to 100,000. Now, in regard of the change in our population, the American Heart Association says the lowest effective dose. And we can say, and there are many studies, and there's also a review, that articaine with 1 to 200,000 is as effective as 1 to 100,000, except this hemostasis in periodontal flap surgery. Other than that, there is no difference, though we should use the 1 to 200,000. For lidocaine, there is a difference. Lidocaine 1 to 100,000 and 1 to 200,000, these formulations with epinephrine are not equally potent. So the 1 to 100,000 in lidocaine in many studies proved to be superior. Therefore also an argument for articaine. Articaine you can use with 1 to 200,000 epinephrine. You lower the risk with the epinephrine for your patient and still have the same local anesthetic efficacy.
Okay. Well, Nigel, are there any absolute contraindications to using epinephrine as a vasoconstrictor for a patient?
The only one I can think of is if the patient is allergic to the reducing agents that have to be in the local anesthetic to maintain the life of the epinephrine. When I was training, I was given a whole raft of indications that you couldn't use epinephrine for, including anyone with even the mildest ischemic heart disease and a whole list of medications that supposedly interacted with the epinephrine. But as time passed, the evidence is more and more that actually most of it is not evidence-based, it's purely myth. Some of it's based on complete and utter pharmacological nonsense, and therefore the epinephrine is the best vasoconstrictor to use with your local anesthetics. But as Wolfgang has pointed out, what we should be doing is keeping the concentration down. Because one of the other things around about that, and one of the myths that I was brought up with, was that if you had patients with ischemic heart disease, you must use fellipressin as a vasoconstrictor. Now that's an interesting argument, because one of the effects of epinephrine is it is a selective vasoconstrictor, so it actually dilates the coronary arteries. Fellipressin is a non-selective vasoconstrictor and it therefore constricts the coronary arteries. So why would you give a patient with ischemic heart disease a drug that constricts the coronary arteries? And if you suggest to a cardiologist you might do this, they turn white in your presence and just say, no, keep the dose of the fellipressin really low. So I say that's the allergy to the reducing agent is the one absolute contraindication I can think of.
Well, we'll need to move on shortly, but Greg, your comments about consent have raised at least a couple of eyebrows. The suggestion is that without really informing the patient of the possible adverse
effects.
That's right.
Yeah.
Are there any specific guidelines in Australia at the moment in that regard?
No, there's none at all. And I mean, the effects I think are fairly well known. Yes, you may be number for longer than you think you're going to be, but as far as the safety of the particular drugs we're concerned, there's no real, adverse effects on them. So, why would we need to get a signed consent for that?
I would just say that I think the one exception to that would be if a patient actually said to you, is there any chance that I might have permanent nerve damage? You would have to answer that honestly and say yes, but the risk is this.
Less than 1 in 10 million.
Yes. But for that level of risk, to actually be going into that amount of detail, I don't think you'd find anyone who would actually say that you had to explain complications that were that rare.
I think it'll be an interesting space to watch at the Australian Dental Congress in Adelaide earlier this year. Professor Tony Poggerell was talking about how in California, I believe it's now standard to have a local anaesthetic consent form. Given Australia seems to be following the US in a legal setting, I guess that will be something to keep an eye on. But let's get to.
I'm still not convinced that our patients aren't as dumb as some people think they are.
I would like to add maybe one thing to the concentration of epinephrine.
Yeah.
It's of course the amount of epinephrine, not the total amount of epinephrine, but the amount you're administering with certain injections a certain period of time. The half-life of epinephrine is very short. It's only 2 to 3 minutes. And now the new recommendation is if you administer epinephrine, maybe in a concentration of 1 to 100,000, not to give more than 4 milliliter at once. After a couple of minutes, when the epinephrine is out of the bloodstream again, then you can give additional doses. What's dangerous with epinephrine is when it comes in the bloodstream. Not for us here, we are healthy, but if you have a patient with cardiovascular disease, and then all of a sudden the pulse rate goes up, and maybe the blood pressure, the systolic blood pressure goes up, that's the risk for this patient. And therefore we should reduce for an injection at once the amount to 40 microgram. That's according to the calculation 4 milliliter of 1 to 100,000 or 8 milliliter of 1 to 200,000. That's, I think, the newest recommendation in regard of risk patients.
I think on the other side of things, on as far as risk is concerned, if a patient comes in and they say they're allergic to that local, until you prove otherwise, you've got to believe the patient.
Or to adrenaline. I have some patients who are sure they're
well, you can't be allergic to adrenaline, but they are more likely to be allergic to the metabisulfates and sulfates in that. In fact, we've had a couple of cases in Queensland that ended up in almost tragedy over that. The actual dentist didn't believe the patient.
So the answer is then, without epinephrine, plain solution. Plain solution doesn't have sulfates, no additives at all. And we can oversee also this in regard of allergies to articane. We have no documented and proven allergy against articane. There is no.
Well, we'd better carry on. Every dentist has experienced a situation where the blessed tooth just won't go numb. Who wants to talk us through their ways of managing a hot pulp?
I'm happy to start. In my experience, the ones that usually cause the problem are lower molars. And you get the frustrating situation that the patient exhibits all the signs of an effective inferior alveolar nerve block. The lip is completely numb, but yet the tooth still isn't. My first port of call is to check that the lip is actually numb and not just tingling. Then I tend to work on the basis of actually blocking the nerve in as many places as possible. Because one of the effects of the hot pulp is it produces what's called hyperalgesia, which effectively lowers the threshold for the action potential being propagated. So therefore the nerve is more difficult to block. The other thing about it is that the nerve impulse jumps bigger distances. So it jumps more nodes of Ranvier than it would do in a normal situation. So my strategy is a conventional block, a high block such as the Akka Nosie or a Gao-Gates block, a buccal infiltration with Articane, a lingual infiltration, although there's less evidence that lingual infiltration works, but if you're doing the lingual infiltration, you have to follow the concavity of the lingual surface of the mandible down to get the local anesthetic close to the apex. Intraligamentary injections. Also inject into the retromolar pad, because there is some evidence that you can get some branches of the buccal nerve and the inferior alveolar nerve entering at that point. And my oral surgery colleagues tell me that often when they think they've anesthetized a molar, if you probe that retromolar pad area, it's sensitive, and injecting in that area can help. And then the ultimate last port of call is intrapulpal. And I would have to say, in all of the years I've been doing this, I've only once got to the point that I needed the intrapulpal to get the anesthesia. And so basically what I'm doing is, it's a bit like you would hear when you talk about risk. Risk management involves not making sure that the hole through the cheese doesn't line up. And by having multiple slices of the cheese together, you decrease the chances of the holes lining up. By blocking a whole number of sites, you decrease the chance of the impulse being able to jump past your local anesthetic. And certainly in my hands, that seems to work.
Greg, do you have any tips?
Just another thing is that on that is the one thing you don't do is do the same thing again. Yeah. Because I mean, it's failed once. Why are you doing it again? It just feels keep repeating the same mistake, don't they? Yeah. So I definitely wouldn't do that. I'm not a fan myself of the interligamental injection, but certainly I would agree with you. The buccal and lingual infiltrations, along with the inferior dental block, and injections in the retromolar pad area where you're doing the ipsilateral nerve. Yep, I think that works well.
I was making, from the description, I was going on the basis that your first block had produced the clinical signs of anesthesia. Yes. There was another question about blocks failing completely.
Yeah.
And
if it fails incompletely, then I do another block, but I don't do it the same block.
Absolutely.
Yeah.
Wolfgang, what's your surgical experience in that?
I would like to add one new aspect to this, and I have to come back to the pharmacokinetics and pharmacology of drugs. Yeah. The problem with the sodium channel in inflammation is that we have inflammation mediators like prostaglandins. And these prostaglandins can activate sodium channels. They are very less sensitive to local anesthetics. And there are studies proving if you do a pre-medication 1 hour before the treatment of a tooth with pulpitis with a non-steroid anti-inflammatory drug like Ketorolac or ibuprofen, you will increase the efficacy of the local anesthetic. And this is evidence-based, because with the lower amount of the prostaglandins coming to the sodium channels, and therefore inactivating the potency of the local anesthetic with the pre-medication and reducing the amount of prostaglandins, you can increase the effect again of the local anesthetic. And other than that, well, I totally agree with Nigel, because you have to do an application in different sites and in order to overcome the problem of the hypersensitivity. And if the pain of the patient already lasts longer time, it's even harder then to overcome this, Then we have the problem also that the central sensitization is an effect. Central sensitization means it's a nerve with the pain producing also this pain over longer time, and it's then much harder then to overcome this acute pain. And in our surgery, what we have, of course, we have always the possibility then to give systemic drugs or give a sedation in order with maybe with fentanyl to overcome it when we are in a surgical setting.
If I just add, I think one other thing that I always tell people is that if you're going to go down the route of trying to extirpate a tooth with a hot pulp, what you need to do is to get the patient numb and get the pulp out. So often I see people who get part of the way and then they put some form of medicament on the pulp and tell the patient to come back in a week or so, hoping that the medicament will have done wonders. But actually, by interfering with the pulp but not extirpating it, what they've done is they've increased the inflammation in the pulpal tissue, and actually they're then asking an awful lot of their medication over the following period. Although I do appreciate that the time that the patients present with this problem is never the time when you've got a space in your appointment book that allows you the luxury of time to deal with it. You always end up with these patients arriving when you're already running late, and the patient afterwards is the one who is always going to be the one who complains about being kept waiting.
One of the joys of dentistry.
I think one of the other things that help us when we're looking at problematic lower blocks is looking at the anatomy and radiographic evidence. So quite often people have different places where their foramens are, and I think if we can refer to those to help us, it's a real advantage. And not everybody obviously has an OPG, but it may be if somebody reports to you, I've always had trouble. Why not get an OPG?
I would agree, and I mean it's been known for a long time that the mandibular foramen isn't in a constant position, and the norm in adults is if it's not in the normal position according to the anatomy textbooks, it's higher and it's further posterior on the mandible, which means that when you use your conventional block technique, your local anaesthetic's deposited in the area where the nerve's nicely protected by bone.
That's exactly.
That's all good to know. Does Articane have the capacity to diffuse across that bone more readily than other anaesthetics?
Absolutely.
Yes.
Yes.
It would.
Lipid soluble.
It showed increased efficiency also in administration of inferior alveolar nerve blocks. But the main point is, and they both mentioned it already, is the location of the foramen. And if you ask dentists why they don't like inferior alveolar nerve blocks, and I ask them all the time when I do courses, the answer is we have no reliable landmarks to know where the foramen is. And my answer is always the same. Do orthopantomogram and look at the orthopantomogram and see how different the location of the foramen sometimes if you use a normal technique. Actually, this was the finding of Gogates. He did a lot of studies in cadavers and found exactly that the foramen usually is higher and more posterior located. And this was this idea to overcome this disadvantage of the classic inferior nerve block, and he recommended the Gogates block. The application of the local anesthetic in a higher position, this allows the local anesthetic to diffuse down and therefore reach a sufficient nerve block.
Well, we'd better keep moving. We've had plenty of questions on special groups. So, for example, pregnancy, lactation, pediatrics, and medically compromised patients. Nigel, do you have a go-to anaesthetic for pregnant patients?
Yeah. It's called Articane with epinephrine.
Okay, that's good to know because we had specific questions. Is Articane safe in pregnancy?
I mean,
safer.
It's safer on the grounds that its shorter half-life means that less of it is going to get to the baby. One of the other myths I think around pregnancy that's very worth dispelling is, again, when I was a student, I was told that one of the things that you mustn't do with pregnant patients is give them prilocaine with felipressin, because felipressin is related to oxytocin and you will induce labour, which is a lovely pharmacological argument but has one fundamental flaw, and that is the amount of local anaesthetic you would have to give the mother before you induced labour would mean that the mother died of prilocaine toxicity before labour started. But it's the right answer for the wrong reason. The biggest problem with prilocaine in pregnancy is the fact that because it's the smallest molecule, it's the one that traverses the placenta most, and therefore it is the one that it means that the fetus is actually going to get exposed to more local anaesthetic than with most of the other ones. So therefore my first choice would be Articane and my second choice would be lidocaine.
Well, Greg, lignocaine, the last check I did, was considered totally, substantially safe during pregnancy and lactation.
Yes.
Articaine at that time seemed, more or less, it was category. It was some other category.
B3, I think, or something like that.
Essentially, there was no sign to show that it was unsafe, but it just hadn't been around long enough and studied.
Essentially, because nobody's going to do a prospective cohort study on a group of pregnant women and inject them. It's just not going to happen. But the evidence suggests, from 1976 in Germany, they've been doing billions of these injections, and pregnant women included, and there's been never any reported adverse reaction to that. And I think that's the strongest evidence that we've got that it's safe.
One of the other things I think it's important to add at this point is historically there's been quite a lot of resistance in the dental profession from doing dental treatment on people when they're pregnant. Mm-hmm. There is actually an interesting review that was published in 2017. The first author was Lee, and actually it was advocating the fact that dental treatment should be provided in pregnancy so that you prevent any of the pregnancy-related problems from occurring.
Right. Yeah.
And their conclusion was that local anaesthesia in pregnancy was entirely safe and appropriate.
Yes.
Well, let's move on from the unborn child to paediatrics. Is articaine safe to use in paediatric patients?
Yes, it is. We did a study some years ago about the pharmacokinetics of articaine in children. Actually, we took blood samples during a surgical procedure in general anesthesia, and then were able to find out about the blood concentration of articaine in these children. And the half-life of articaine is lower, even lower than in adults. And the half-life is about 17 to 18 minutes. That half of the articaine circulating in the bloodstream in children is already gone after 13 to 18 minutes. So there is no need to either use other drugs. The second thing is there is an increased safety because of the short half-life in the drug. We know the toxicity is related to the half-life. Another thing is also that's important for children. We don't have to recommend a lower maximum safe dose for children. So in Germany, in Europe, we have, and I think we should use it worldwide, 7 milligram per kilo also for children. And there is no need from the pharmacokinetics to alter this maximum dose recommendation in children.
And the 7 milligrams per kilogram, because we've had a question about that, does that apply to articaine and other local anaesthetics?
It applies to all amide type local anaesthetics with epinephrine. For epinephrine, for local anesthetics without epinephrine, it's I think in the 4 milligram per kilogram. But for children, for articaine, it's 7 milligram. Of course, in children, as in patients with low body weight, you always have to calculate the maximum safe dose individually. And if you have a child of 30 kilo, and then of course you have to calculate the individual maximum safe dose and not going by cartridges. Or if you have a child with 20 kilo. And if you look in the literature, toxic reactions in pediatric dentistry occurred by using dosages, fixed dosages in cartridges. And if you do the individual calculation, that can be a dangerous procedure. So articaine is safe for children, but of course you have to take into consideration the maximum safe dose, 7 milligram per kilo. And then there's another advantage. Maybe you do a procedure on the nitrous oxide and it lasts in a child or in a sedation for maybe 45 minutes to 1 hour. Then because of the short half-life, you can give additional doses again above the calculated maximum safe dose because of the short half-life. I would say that after 30 minutes you can apply another 25% of this calculated maximum safe dose without the risk for toxic reactions. And this is therefore no reason to not recommend articaine also in pediatric dentistry.
I think the biggest issue with children is accidental intravascular injection. If you did that, then obviously you run into trouble. But in that regard, lignocaine's worse than articaine because of the protein bonding. I wouldn't. I just do infiltrations for all my children, all children, because buccal infiltrations on lower sixes work.
For an extraction of a lower E, for example, though, what would you use?
Articaine every time.
As an infiltration only?
As an infiltration buccal lingual.
Yes.
I mean, I think the reason that some countries, and I think the UK is one that's lagged behind in recommending Articaine for children is the fact that we've been relatively late adopters of the drug and have been perhaps reluctant to learn the lessons from our continental European colleagues in terms of their experience. And in kind of the same way as Greg was talking about for pregnant women, it's very difficult to actually get the ethical approval to do the studies. So therefore, people tending to shy away from gathering that data, but actually looking internationally, there is sufficient evidence to say that it is actually perfectly safe in children.
Well, can we stick with you for a moment, Nigel? What are the main medication interactions we should be mindful of when it comes to local anaesthetics? And I'm sorry, this is not intended to be a pharmacology lecture, but
okay.
What are the main red flags you look for?
The main red flag I particularly look for is one with epinephrine, which is the poorly selective beta blockers, particularly propranolol, which is a very old beta blocker and also has a degree of alpha blockade as well. And they are well known there is a well-known possibility of hypertensive crisis. It's quite rare, but it has been described in the literature. Historically, there have been things suggested such as tricyclic antidepressants, monoamine oxidase inhibitors. In fact, the evidence is that there isn't actually a problem with those drugs now. So really, with the exception of propranolol, there's very few drugs that I would be significantly worried about.
The list when we went through was quite long.
It was huge. I mean, but as I say, we now know that most of that was actually not evidence-based and actually has no backup in terms of
with monoamine oxidase inhibitors in general, it was because they said, oh, it's going to interfere with the adrenaline, metabolism.
But the adrenaline and monoamine are metabolized in completely different ways, and there's no real interaction at all.
I would say also the doses again. We are the concentration and the dose you administer. It's not an absolute contraindication anymore. All these drugs we discuss, they might have an influence. It's not clinically proven. There's no evidence. But of course, we should reduce the amount and we should reduce the concentration. So going with the recommendation not more than 8 milliliters, 1 to 200,000, 4 milliliters, 1 to 100,000 at once, and not higher than 1 to 200,000.
And with any medically compromised patient, you need to look at their general fitness, and as their fitness decreases, your maximum dose of local anaesthetic for the patient should decrease. So where we have talked about a dose of 7 milligrams per kilogram for us who are relatively fit and healthy, if you're dealing with an elderly and frail person, you might drop that to about 4, or even perhaps down to 2. If you're concerned about their ability to cope with the treatment. But it's an individually adjusted.
Again, we have then the interference with the drug. I can imagine in very old patients that they have a low amount of plasma proteins. Plasma proteins are going low, so the protein binding might be a factor. But we have studies also performed the kinetics of Articaine in elderly patients, and again there we had no difference to adults or to children. It's 27 minutes half-life. The protein binding might be a factor if patients really have maybe plasma albumin, a lower rate. Then of course they have a lower plasma protein binding. But I doubt if this has an importance for the local anesthetics as well. So for elderly, because the liver metabolism, that's important for all other local anesthetics, amide type drugs, is not important in elderly for Articaine, because Articaine is still metabolized 98% by the esterases. So the liver metabolism in elderly risk patients doesn't make a difference. It makes a difference to lidocaine and also to other typical amide types again. So it's safer. And we can of course use the lower amount of epinephrine. I think these are the most important factors for elderly risk patients, and the recommendation of the World Health Organization also to blood pressure measurement in the dental office of these patients, measure blood pressure, pulse rate, when you administer, before you administer. You have to know the patient, and this includes of course blood pressure measurement. This is, I think, a safety issue in elderly.
Well, we'd better move. Oh, go on.
Sorry, one of the big problematic areas I find is the low weight female patient who's about 40 kilos.
Yes.
And, you know, why is she 40 kilos? Is that because of her physiology is that way, or has she got some underlying problems with anorexia and or bulimia, or even IV drug use? IV, they're problematic because they usually got lots and lots of work to do. Yeah, so you can easily overdose those. Yeah, and plus the fact is they have poor liver function.
Well, we'd better move on to some of the nuts and bolts techniques, tips and tricks. What's the current recommendation when it comes to injecting with the operator's fingers in the patient's mouth?
I come from the UK where that's what we do. And there's no question about it. And students that I've taught in the United Kingdom, if they didn't have their fingers in the mouth and had a mirror in the mouth, they would get taken aside and told that they were wrong. Interestingly, I was at the IFDAS meeting, the International Federation of Dental Anesthesiology Societies in Japan last October, and every presentation that I went to that was talking about local anesthetics, every single clinical illustration had the fingers in the mouth. If you're talking about inferior alveolar nerve blocks, one of the key landmarks is the maximum concavity of the ascending ramus. You can't find that with a mirror. You can only find that with a thumb. And then the height of the injection is the midpoint of your thumbnail. So if you've got a mirror, you can't do that. The other thing about it is intraoral injections. If you don't stretch the tissue, you hurt the patient more. And you can't stretch the tissue adequately with a mirror. So actually you see better when your fingers are there. You can distract the patient by saying, you're just going to feel me squeezing your lip or your cheek very tightly, and I squeeze the cheek as the point of the needle goes through the soft tissue, and it distracts the patient. If you can't do that without stabbing yourself, I would question whether you have the dexterity to be a dentist, because it's not that difficult. And in my experience, the majority of needle stick injuries occur when people are doing things like trying to resheath needles, or if they're doing something daft or stupid outside the mouth. But in my experience, needle stick injuries don't occur in the mouth.
Well, Greg, my understanding is you have some tips or like a suggestion for how we can help to reduce needle stick injuries. What can you tell us?
I think the best thing that ever came into Australia was the Ultra Safety Plus thing, which is a very safe way of delivering local anaesthesia to your patients. And I think you've got a video on that.
I believe so.
Maybe we could bring it up and talk about it while we...
Yeah. I mean, I would agree, because every UK dental school teaches this particular technique. And what you have here is a piece of equipment where you slide the local anaesthetic cartridge into a disposable barrel, which is then attached to a handle. This particular one, being black, is autoclavable, but you can get a white disposable one. You then slide this outer sheath back until it clicks into place and locks the barrel. You have an aspirating mechanism where there is a projection at the needle end that will actually distort the diaphragm. When you want to change it, you pull this barrel down, and there's a first click which allows you to actually protect yourself from the needle and change cartridge. You can then pull the sleeve back and reuse it. You can change, and then when you're completely finished, what you then do is you press the barrel down to a second click position where it locks in place, as that has just shown. And at that point, you cannot pull the cover back. The cover is significantly longer than the needle, even if you're looking at a long needle, which they do make. And it becomes very, very difficult to actually needle stick yourself with that. About the only time that you can do it is if you have actually bent the needle, and you've bent it so that the point is against the outer sheath, As you then try and pull it back, the needle can cut through. But properly trained, it significantly decreases the chances of a needle stick injury. Much safer than all of these funny techniques where you try and pursue the cap of the needle around the bracket table to catch it.
The one-handed
techniques.
Or where you wander across the surgery having given the injection to then go to find your sharps bin and drop the needle in.
Well, it meets the guidelines of the ADA as far as resheathing and that's concerned. And since I've actually adopted the UltraSafety Plus, I haven't had one needle stick injury in the surgery, and I mean it's the responsibility of the dentist as well. In fact, I've moved on to, there's a new one out there which is the XL, which has got a bigger lumen and sharper needle. And I tell you, it's lovely to use.
Changed your life.
Yeah, love it. You know that you can get it in 27 gauge, you can get it in 30 gauge, you can get it in short and long. No, I just think they're the bee's knees.
I think the other thing about these is the quality of the needle.
Yeah.
A few years ago, I was fortunate enough to go to Septodont's needle factory in Mazamet in France, and was able to see the process. And the most impressive thing about the process was the quality control and the number of needles that were actually discarded on the way through the manufacture process. Because going right back to where we started, I'm a firm believer that one of the main reasons for the paresthesias is physical trauma. And I think using blunt needles with deformed tips is a very good way of producing that trauma. And if you look at the publications that have reviewed the quality of dental needles, some of them are quite frankly shocking in terms of the tip profile. Whereas, as I say, my experience of the UltraSafety Plus is that the quality of the needle, as tested by how easily it punctures and glides through tissue, is excellent.
And it's possible to use your needle of choice on the UltraSafety Plus.
That's what I was talking about.
There's a complete range of lengths and diameters available.
If you're interested in trying the UltraSafety Plus, I understand that Henry Schein and Septodont do have a viewer special, but it's only for the next couple of days, so you might want to get onto that as soon as you can. It certainly sounds like something worth trying, gentlemen. That brings us to another question that we've had about the process of bending needles. Is that ever recommended? Wolfgang?
In Germany we don't use it, and I think it's not so common in Germany, but I know that it's very common. Nigel told me in the United States. But my advice is you should never bend the needle, of course not, because then you have the risk that you might have a needle breakage. We had this in the 60s and the 70s when we had a low quality of needles. Nowadays you hardly see a breakage of a needle, but of course if you bend it and where it attached then there, and this is I think the weakest point, then the needle can disappear into the soft tissues. It's very, very hard from the surgical point of view to recover such a needle and take it out of the soft tissue. So my advice is never bend it. I see no need to do it.
And I think the other thing is, if someone does have a reason where they feel that they must bend the needle, the one place that you mustn't bend it is at the hub.
Of course.
You can get away with bending it part of the way down the shaft of the needle, but do not bend it at the point where the needle comes out of the hub.
The problem with that, of course, is that you increase your risk of a needle stick injury.
But hopefully if you're doing it before you've injected it's at least a sterile needle.
Now, bubbles in cartridges. We've had questions about whether bubbles in cartridges are a problem. Greg, can you tell us?
Right. Okay. So there's two types of bubbles that we see in cartridges. You see, and we've had some people complaining to me about little tiny bubbles in their anaesthetic cartridge. Now that's usually a transport problem, right? It's not some reaction that's happening in the cartridge. If you flick it a couple of times, usually the bubbles come out. You're not going to give somebody an embolism with that much air in your cartridge. I think you need something like 20 mils to cause an air embolism. So significantly, you'd have to have that's 10 cartridges. You'd want to be really trying hard to kill somebody with that.
10 cartridges with no local anaesthetic in them.
The other one is when you actually see a single bubble. So there's an ISO definition or that you've got a standard on that.
Yes.
And if you can hold the cartridge upright and you can see the bubble below the metal cap, then you should discard it. And certainly if you see any discoloration in your local anaesthesia cartridge, you should discard it as well, and inform the supplier.
So we've had some questions from Facebook about cartridge storage. Is it important to be storing them in a locked fridge?
I would say it's important that you don't store it in a locked fridge. You should store it at less than 25 degrees centigrade, but it doesn't have to be stored in the fridge.
It can be problematic in Australia where you've got temperatures that are outside that are significantly higher than 25 degrees at times, and it's certainly when the air conditioning is turned off at night, that can climb well beyond the 25 degrees. So most, I think, surgeries in Australia will store it in the fridge, right, and remove it before use, up to an hour or so it gets to room temperature. Should never, ever, ever warm a cartridge.
No.
That's pre-answered a question. Yes. Why should we not ever, ever, ever warm a cartridge?
Well, at 40 degrees C, you're going to denature the proteins in the actual local anaesthetic, so not advised.
And the other thing about it is that it's often been said that if you warm it, it's nicer for the patient. It's not as uncomfortable.
Yes.
But actually, provided the local anaesthetic is somewhere between 15 and 35 degrees centigrade, the patient won't actually notice any difference. So,
this was also one of the myths about the pain during injection. It's the injection speed, the pH of the solution that's much more important. The temperature doesn't play a role, but many dentists still believe they have to warm up the scalpel in order to give or to administer a painless injection. But this is, I think,
and I mean, if you think about it, the needle that it's going through into the patient as it passes through the patient's mouth is an ideal heater or cooler. Because if you think about how you want to heat or cool fluids, you put them through a very narrow metal tube that allows heat exchange with the external environment. And as the patient breathes while they're having the local anaesthetic, particularly if you're giving it slowly, then it will come to that sort of temperature that the patient will accept very, very easily. So there's absolutely no reason to have a cartridge heater.
Let's talk about blister packaging. Does it matter if a carpula is supplied in blister packaging or if it's in a tin that is supplied by the manufacturer? Essentially, are we worried about compromising the sterility prior to use? And if they are supplied in blister packaging, is it a problem if they're dispensed hours, weeks, months in advance?
It should only be taken out of the blister pack just before usage. Okay, it is not sterile in that. Let's be honest. It's not a sterile environment. It is a very clean environment. The solution inside is sterile, right? But if you've got a cartridge that you leave out, then it's going to be even less clean, and potentially you've got contaminants occurring on the little seal, and that may be a problem.
A question we had submitted by a viewer who registered ahead of the event is, if the use by date of the solution is over by 6 months, is there any danger to the patient in using the solution?
And the answer to that is, I don't know of any direct evidence to show that there would be a danger, but you should not use any pharmaceutical product beyond its use by date.
That's right.
Because if you do and there's a problem, you have no defense against that.
We've got to remember that we're doing elective treatment as well.
Yeah. So, as I say, I think to use it beyond its date is indefensible.
Yes.
Good advice.
That's right.
Let's talk about dosage. Is there any hope that the uniform 1.8 mil dental cartridge will be adopted in Australia?
No. Simple answer is no. Okay. It's a purely marketing thing that I understand, but there's no plans at all to do a 1.8 cartridge in Australia.
Again, I think one of the myths that people have is if they magically went to this cartridge that was that much smaller, it would suddenly magically be cheaper.
No, it's not.
But actually, when you look at the costs of producing it, in terms of that 0.4 mils of local and the slightly smaller cartridge, actually the there is no difference in the cost of producing it, because the whole of the process is the same.
Yes.
And I think that if you tried to sell that to the profession, probably you wouldn't get very far. So,
yeah, and
it's the same in the UK. I mean, it's not going to change there either.
And it doesn't mean because you've got 2.2 mil cartridge that you need to dump 2.2 mils into somebody's soft tissue.
Yes. Then another thing, I think dentists love to calculate maximum individual doses by cartridges.
Yeah.
But I think we should come to the point that we really ask them to calculate in milliliters,
Grams.
and then it doesn't make any difference if it's a 2.2 or a 1.8 in regard of safety.
Yeah.
Then I think a dentist should do the calculation, and
Absolutely.
must be able to do the calculation. And therefore I see no need also for safety reasons and to reduce the amount. So if you administered 8.8, if you administered 4 cartridges, or maybe only 6 when you use the 1.7. So I think you have to calculate individually. That's the point.
Wolfgang, let's stick with you. If my lignocaine injection doesn't work, whether it's a block or an infiltration, can I use articaine at the same site? If yes, how much can I give?
Yeah, we are still with the maximum dose recommendation for all AMI type drugs. It's 7 milligram per kilo. And if he already administered 5 maybe milliliter, and the maximum calculation for this patient is maybe 10, then he can maybe give additional 5 milliliters of articaine. But I question the need to change the molecule in the same patient with the same procedure. We heard about the risk when we discussed the risk that maybe articaine is related to a higher risk of neurosensory disturbances than giving first a local anesthetic, yet you consider less effective. And then if it doesn't work, you use then articaine and give a second injection in already anesthetized area. Then indeed you will increase the risk for possible nerve injuries. So I see no clinical need to first start with lidocaine for nerve block and then switch over to articaine when you see it was not sufficient. Generally, you can use different local anesthetics in one patient if you see the maximum dose recommendation and if you apply the maximum dose for this individual patient. But for me it doesn't make any sense. So why not going with articaine firsthand?
I think the only other thing I would add to that, if I may, is a comment that Greg made earlier, that if your first injection hasn't worked, don't do the same thing again. So if an injection in a site with one local anesthetic hasn't worked, then I would be saying, why hasn't it worked? Let's think about why it's not worked. If it was an infiltration, is it because the tooth is longer than you thought, and actually what you need to do is to put the local anesthetic higher up? If it's a block, is it because the foramen's not where you expected it to be? And therefore you shouldn't just be thinking that magically if I just use a different solution it's going to be effective. It's going to be the whole package. So you probably wouldn't be going into exactly the same site.
All right. Well, obviously we're running over time, so gentlemen, thank you for your endurance, and thank you for watching. If you have to leave us now and would like your CPD certificate, you can claim that by going to the Henry Schein website and clicking the relevant button to claim your certificate. But for those who can stay with us, we still have plenty of good stuff to get through. Let's talk about toxicity. We've had some interest and some questions about the relative toxicity of different anesthetic molecules. Wolfgang, what can you tell us?
Well, like I mentioned before, typically AMI-type local anesthetics are metabolized in the liver, and that's a process that takes some time. And the individual maximum, maximum dose of lidocaine, perhaps, is calculated maybe at least for 2 or 3 hours. So you can't give with a typical AMI-type drug additional doses succeeding over the calculated maximum safe dose. Articaine is unique because it has an ester link, and the toxicity is related to the time of the local anesthetic in the bloodstream. So if after 30 minutes already half of the concentration in the bloodstream is diminished or is metabolized, then you can go with additional doses above the calculated maximum dose. And therefore, articaine is a typical AMI type, but of course the metabolism is different, and it's different to all other AMI type local anesthetics.
I think the drug that is the one that has the highest toxicity is bupivacaine.
Yes.
Because it has by far the lowest maximum dose.
Yes.
And the other thing about it is it's the drug that binds most strongly to the heart muscle, the myocardium, and therefore if you inject it intravascularly, it can be exceedingly dangerous. We don't tend to use it an awful lot in routine dentistry because it lasts so long and the patients don't like the numbness. What I can't understand is why people still want to use it when there's an alternative available called levobupivacaine, which is an isomer of bupivacaine, has exactly the same local anesthetic effects but none of the cardiotoxic effects. But as I say, in terms of toxicity, bupivacaine is the one to worry about.
Well, but
and
all
I
the
think
others.
also with bupivacaine, going back to pregnancy, it also is the one where the toxic level is most, or the threshold for the toxic levels, most greatly affected by the hormonal changes in the mother.
Well, Marcaine or bupivacaine is not available in dental cartridges in Australia at all. Anyway, there has been some talk about it. Personally, I don't find it as efficacious as articaine. It's certainly the paresthesia that they get from it is not as deep. As far as oral surgery is concerned, I think it's a good post-operative pain control.
That's the indication.
That's where it stops.
Yes. For therapeutical local anesthetics also, if we have patients with unknown facial pain, and then we block this area for a long time, and then the patient is still pain, then we know it's nothing related to this area. But if you are able to overcome the pain with a therapeutical local anesthetic for 3 or 4 times, then of course you have proof that maybe the pain might be related to this area. That's the indication we use it. Other than that, I see no indication for bupivacaine for routine dental procedures, not at all.
We've had a recent question about whether articaine is safe for a block. So I suspect this person hasn't been able to see the entire webcast. To summarise, I believe it's as safe or as dangerous as any other local anaesthetic. But if you'd like to get the longer discussion, this discussion will be available on YouTube on the ScheinTV channel. Moving on, how would we recognise local anaesthetic toxicity, Wolfgang?
Local toxicity is related to 2 organs. The first is the brain, and the second is the cardiac problem. So if you have a blood level of local anesthetics above, maybe it's for lidocaine or articaine, it's about 5,000 nanogram per milliliter, then you might see the first reaction, toxic reaction in the brain. The patients report then they feel a metal taste on the tongue. They have different sensations also, and if it's go on and you have even higher levels, then the first sign is seizures. Seizures occur then. That's in the brain, and in the last consequence also, because local anesthetics block all kind of neural structures, not only the sensible nerves, they also block also in the heart, of course, the membranes, and then the heart stops to beat. That's an asystole. That will occur if you have a high intoxication with local anesthetics. So therefore every dentist should be trained to overcome these problems in relation to toxicity. And it's oxygen that must be present, and for the things with the brain problems, it's of course the benzodiazepines. Benzodiazepines are anticonvulsive. That's in Germany, it's a must. Every dentist to administer local anesthetics must have this drug in his emergency kit, and it's epinephrine, of course, in case of an asystole. Yes.
I don't feel as though diazepine or benzodiazepine not a big thing in Australia.
No, it's not. The essential things that we need, if you're giving any local anaesthetic, must be that you have to have portable oxygen, because guess where the patients collapse? They always collapse in the waiting room or the car park outside. They don't conveniently do it in the chair. Well, some of them don't anyway. You must have a oropharyngeal airways and know how to put them in. Bag valve masks so that you can actually deliver something close to 100% oxygen to that patient. And you must have adrenaline but that's primarily in the form of EpiPens for allergic reactions. They're the essential things. There's a whole list of desirable drugs that are listed in the ADA guidelines, therapeutic guidelines. it's probably worthwhile somebody picking up page 188 and having a look.
If I can just add, I think the most important management of toxicity is prevention.
Yeah.
Don't get there. And the two key things around about that are, first of all, set your maximum dose and don't exceed it for that patient. And one of the tricks that I have around about that is I set my maximum dose, and then I would never at the start of the procedure give more than 75% of that maximum dose, so that if I do have an issue with a local anaesthetic failing, I've got 25% I can fall back on. The second thing is that in addition to getting toxicity from an absolute overdose, you can get toxicity from a relative overdose, which is where you get a high plasma concentration because you've injected intravascularly. And the two tips I would have behind that is that always aspirate twice before every injection, without exception. And the second is to inject very, very slowly.
That's it.
So that if inadvertently your injection is intravascular, by the time it reaches the myocardium and the central nervous system, it will be more diluted because it's going into the bloodstream at a slower rate, and hopefully you will then actually pick it up before your plunger has reached the end point that you were thinking about.
Well, thank you for that, because we've had several questions on aspiration, and so yes, if we aspirate, you said twice before every injection ever,
Yes.
we're good to go.
And if you've shifted the point of that needle, do it again.
Before we move on, we've had a question, what was the recommended alternative anaesthetic? I think, Nigel, this relates to the anaesthetic you were talking about related to bupivacaine.
Bupivacaine.
I don't think it's available in Australia.
It's levobupivacaine, Levo bupivacaine. Whether it's available in Australia, I don't actually know,
it's not.
But it would be the one I would go to if it were available.
And for goodness sake, don't buy it overseas and try and bring it into Australia. That's foreboding.
Good to know. We're running short on time, so if I can ask for fairly short answers, I'm sorry, I know there's a lot to say. Wolfgang, what should we be aware of when injecting into or around foramina? For example, the mental foramen.
Not in the foramen, of course not, but around, and there's nothing to say to do this as closer to the nerve as better. Of course, if diffusion will be better to the nerve, but it is not advised to give an injection into the foramen. Then, of course, we can cause direct problems with hitting the nerve, putting the local anesthetic in the nerve, bleeding, and all the described side effects we had for the explanation for neurosensory disturbances, not in the foramen.
One of the tips I do is when I'm looking inside, I actually palpate the foramen first, and then put my finger on that foramen and then inject near it, that finger. So I avoid injecting actually into the foramen.
And again, by hitting the mental nerve directly, you will have the same reaction of the patient like with an inferior limbar nerve. A patient doesn't like you to hit the mental nerve with the tip of the needle, so the patient will show you if you are directly with the needle tip in the nerve. Yes.
But you can manage to do that without actually sticking the needle in your finger.
Absolutely.
That's a good thing. Nigel, what's your suggested needle gauge for different techniques? For example, infiltration, block, PDL, intrapulpal.
Okay, for blocks I tend to use a 27 gauge because all of the reports of needle fracture are for finer gauge needles. Yes. For infiltrations I tend to use finer, either 29 or 31. It's an interesting balance because a lot of people say that narrower needles are better. If you look at it, you will find that the narrower the needle, the less the patient will notice the puncture of the mucosa, but the more they will notice the deposition of the solution because it's coming out at a higher pressure, because the pressure of the fluid is related to the third power of the change in diameter. So overall, there is actually little evidence that within reason changing the diameter of the needle has much effect. In terms of intrapulpal, it's what I can actually fit into the intrapulp, because the biggest thing that you need for intrapulpal anesthesia to work is pressure. So if you can't actually wedge the needle into the root canal and gain pressure, you won't gain anesthesia.
All right. Now, how many injections can be given at the same time with the same needle before substantial blunting? Wolfgang, you had something to...
I think whenever you hit the bone, that's I think a mandatory thing. When you hit the bone, you can say that the tip of the needle is deformed, you might have a bend or you have whatever there, then you should change the needle. Yes.
Okay. Greg, should we be buffering? If so, which technique is recommended? And for that, could you please explain buffering as well?
Okay, so buffering essentially is one of the things that people say, and Wolfgang alluded to before, is that one of the things that hurts when the needle comes in is believed to be the acid. The fact is that it's a pH of 4. So the concept is that if we buffer our local, that won't hurt as much because you've got a higher pH, right? More the physiological pH of 7.6. And the other aspect of it is because you are increasing the pH, you're going to get more free ions to cross the membrane, right? But in reality, it doesn't seem to make any difference at all. And I think there is no ability for us in Australia. There's no product in Australia that sells that will buffer. It's really, and the real reason is because all the studies, for the last couple of years have all said the difference is minimal.
And the only product I know of is an American product that's based on 1.8 mil cartridges with 1 in 100,000 epinephrine. And if my memory's correct, it's only ever been tested on lidocaine. It's never been tested on any of the other local anesthetics.
And there is some evidence to indicate that it actually affects the adrenaline as well.
Nigel, we've had a question. This person was trained to hit bone when giving a block and then pull back slightly, then aspirate. Don't inject if you don't hit bone. Is that still advised?
Yes, it is, because if you don't hit bone, there is a possibility of you actually being too deep and being in the parotid gland and producing facial nerve paralysis. However, the term hit bone implies that there's a bit of force. One of my colleagues once described that what you were trying to do was to have a soft landing on bone, so that you literally just touch it and feel the resistance, and then at that point pull back.
Yes.
Wolfgang, a question for you. How effective is the Akka Nosie closed mouth mandibular nerve block for extraction in limited mouth opening cases due to facial swelling?
I have no data that it's not as effective as the other techniques. The closed mouth technique is, of course, when you can't get the patient open the mouth and you are forced to give a parallel injection parallel to the ramus, and if you do the procedure properly to this position and you deposit your local anesthetic, I have no data that is not as effective, the Akka Nosie block, as maybe the inferior alveolar nerve block.
But there's no soft landing on bone.
It's a parallel technique. That's a parallel technique. Other than with the location of the foramen, of course. In these cases, when the foramen is in a higher position, you might fail with the Akka Nosie block.
I've used the Akka Nosie block quite a lot and found it effective. The biggest problem I've found with it is that to judge the depth, you need a basically intact upper arch, because you need to have the upper 7 in the correct position.
Yes.
And having spent many years working in areas of poor dental health, there have been a significant number of times when I haven't been able to use it because the patient is missing so many upper teeth that I haven't got the landmarks.
Yes.
But for patients who don't go numb, I find it a really useful technique because it's effectively a high block. So it's taking that altered position of the mandibular foramen out of the equation.
Staying with you, Nigel, direct pulpal injection, should or should we not be using vasoconstrictor?
You should be using local anesthetic with vasoconstrictor, although actually the evidence shows that the main thing is the pressure, not the solution. But I would still use local anesthetic with vasoconstrictor. I'd use the same local as I would use for the other injections.
All right. What is the current protocol for managing transient facial nerve weakness after an inferior dental block?
It's that you need to protect the eye. that if you have the orbicularis, the muscle around the eye affected and the patient can't close their eye, they can't blink, the cornea is at risk of drying out and also at risk of damage from dust hitting the eye. So therefore the eye should be closed and held closed with a patch put over it, which should stay in place until the normal sensation has returned, or the normal movement has returned. Personally, I would like to sit the patient down somewhere and keep them until I actually saw that come back to normal, although I know a lot of people do send the patients home.
I would not send the patient home.
No, I wouldn't.
Facial palsy happens after local anesthesia by penetration, and I think
it's pretty rare.
It's pretty rare, yes, but and it's not a permanent thing.
It's interesting you say that, having taught a postgraduate course on local anaesthetic and asked postgraduate students to reflect on complications they'd had. The most common complication they reflected on was having produced a facial palsy, and without exception, every one of them admitted that what they would do differently is not inject the local anaesthetic for an inferior alveolar nerve block unless they'd actually touch bone.
Yes.
Every single one of them had said that when they produced the palsy, they hadn't found bone and they thought, I'll just do it anyway.
In the direction of the facial nerve,
and they also get that flushing sometimes from it as well. But it's all part of your duty of care, and your duty to care is to keep that patient there and keep them monitored.
Well, we really are short on time, I'm sorry. Wolfgang, we've had a question about, do you experience, or do your patients experience, periorbital muscle weakness using articaine for the removal of upper third molars?
No, you can't say that, no. In my experience, no.
Good to know. And does anyone on the panel have a suggested form of topical local anaesthesia?
The one I like best is benzocaine topical, because for two reasons. One is it acts much more rapidly than lidocaine. Lidocaine works really well, but it takes 5 minutes and no one waits 5 minutes, whereas benzocaine is effective after 1 to 2 minutes. The other great advantage of benzocaine is it's not absorbed systemically, and therefore it doesn't contribute to the maximum dose calculation that you have to carry out. The downside of benzocaine is it's an ester and it has a significant number of preservatives in it, and therefore the potential for an allergic reaction is actually slightly higher than the lidocaine topical.
Right. A question from early in the webcast. Is there any substance to the anecdotes around failed or short duration anaesthesia with Ehlers-Danlos syndrome patients?
Yes, there is. There are some patients with Ehlers-Danlos type 3 who are very difficult to produce local anaesthesia in, but it's not a consistent finding. But you will find occasional patients who, yes, there are difficulties with local anaesthesia for that group.
This person has a question. I have some patients who don't regain full sensation for 5 to 6 hours after LA. Are there any predisposing factors to prolonged anaesthesia? Wolfgang?
Of course there are. It's one thing, the vascularization of the area. This is if the area is not as vascular, and then the transport of the local anaesthetic from the application area is slowed. Then it can be tissue thing. The tissue penetration is different there. It can keep the local anesthetic longer there. It's a concentration, and of course the amount of epinephrine. If you have the vasoconstrictor there acting longer, then of course the local anesthetic stays longer at the site of injection. So these are different kinetic factors that can influence also the duration of the local anesthetic. Epinephrine mainly, then vascularization and type of tissue.
I think we might need
the amount of local anaesthetic the person puts in.
Yes.
I think we probably have to leave this as our last question. I have a patient who's about to get a lip tattoo and has asked me to administer LA. Is that something I can or should do? Greg?
It's not dentistry. Don't do it.
Even though the injection itself is dentistry.
Yeah, I wouldn't do it, right? Just because it's not part of your dental practice. It's not part of your scope of practice.
That's good to know. Look, I'm sorry we're out of time. Gentlemen, thank you again for joining ScheinTV and for this wealth of knowledge on local anaesthesia.
Thank you.
Thank you.
And thank you for joining us. To claim your CPD certificate, head to the Henry Schein website and click the certificate registration button. This episode of ScheinTV was brought to you by Henry Schein and Septodont. Thanks again, and see you soon.